Hey everyone, welcome to another episode of Darshan Talks. I'm your host, Darshan Kulkarni. It's my mission to help patients trust the products they depend on. I'm an attorney, I'm a pharmacist, and I advise companies with FDA regulatory products or FDA regulated products. So if you have an interest in an FDA regulated company or its products, this is the podcast for you. So today's podcast is about innovation. Today's podcast is about telemedicine. Today's podcast is about sharing data. So if you are in medical affairs and you're trying to figure out how are companies, how are physicians, how are healthcare practitioners getting data? If you are in sales and in marketing and you're wondering how are patients and physicians and healthcare practitioners accessing your product, and is this the optimal way you've been operating? Or are you operating in almost an old way of thinking? You'd care about today's conversation. Our guest today is a physician entrepreneur and currently the chief medical officer at Blue Stream Health. Prior to Blue Stream Health, he served as the chief innovation officer at Medici. Prior to Medici, he worked to enable cognitive clinical decision-making technology at the point of care for healthcare practitioners and patients to positively impact clinical learning and quality measures for healthcare organizations, pharma, and payers. Previously, as co-founder and CMO of Health Recovery Solutions, he helped empower patients to better manage their health and improve quality of life using evidence-based interventions, and while also serving as senior medical editor at MD Links. He's also helped create sustainable healthcare innovation via enabling fellows to improve the health of communities by creating innovative technology solutions that deliver transformational impact while molding the next generation of leaders at Health for America. So our guest for today, ladies and gentlemen, Sandeep Pulim, MD. Sandeep, thank you so much for coming on.
Thanks, Darshan. I appreciate you having me on. It's going to be a fun conversation.
This is going to be great. I have so many questions. Let's start with the beginning, which is you have one of those perspectives. I've spoken to a few people like this, but the quote unquote physician entrepreneur, and you seem to represent that so well, because when I think about entrepreneurs, I think what entrepreneurs do is they look at a problem differently, and they don't look at it from I have to deal with this problem. They look at it as how do I solve this problem, and you seem to have done that multiple times in your career. Is that fair?
Yeah, I think so. It was all by accident, right? It wasn't by design. It was, as going through training, medical school, residency, all those kind of things. You're actually learning how to solve problems in your medical career, and you're committing to a lifelong committing to a lifelong career of learning, right? You're a lifelong learner. You learn how to teach yourself. You pick up things, and always making sure that in the context of the doctor, your career path, it's about making sure that you're doing the best thing you can to take care of your patients. But those skill sets actually can transfer really well, I think, in terms of what you do in the business side, for part of that team that you build around you, right? You find a problem you're trying to solve, and then you are navigating the ways to make that a sustainable solution by finding a revenue model, making sure that you have the right fit for the problem that you're trying to solve in terms of product market fit. So yeah, it's just, I think that title, physician entrepreneur, applies to, essentially every doctor, clinician, anybody that's out there, therapist, that's kind of, running their own practice, right? At some level, you're an entrepreneur.
So you say that, but I feel like most physicians, my ex-wife was a physician, you go into the process to help patients. That's always been the core goal. And it's usually a one-to-one helping process. But I'm seeing a lot of people drop out of being a quote-unquote traditional physician to saying, there's got to be something more out there. What was the impetus for you? What have you seen? Why are physicians leaving the traditional taking care of patients one-to-one? What has changed that caused this?
Yeah, I think it's a couple of factors, right? It's always, I think, comes down to, personally, it's always going to be, how much of this perception that you have that I need to fix this, like, what is my internal motivation? Do I have the economic means, the family means to be able to, leave my comfort paycheck and jump in and start something from scratch, right? So that's the second thing. So what's your tolerance for risk? That's why I always ask my friends, like saying, oh, how'd you do this? Or, I want to do this. So the first thing I ask them is, okay, how much are you comfortable not having to have a salary for the next 2 years potentially, right? So if you have, and then what is your comfort level with the risk you're willing to take? And granted, you do the best you can to minimize that risk, but so that's foundationally, I think a lot of physician entrepreneurs that are not in the traditional practice sense, but are actually starting companies. It's about impact, right? They see in a lifelong career maybe 20, 30,000 patients that they're able to take care of, and then if they kind of apply their skill sets to tackling problems that can reach a broader scale, and now you can potentially impact millions or billions of people. That I think is primarily the motivation, is just what level of impact am I able to make. And then for the ones that are choosing to step out of their comfort zone, I think those are the first kind of couple factors that you have.
It's funny, you talk about impact, you talk about tolerance for risk, you talk about internal motivation, which are incredibly important, but you're truly a entrepreneur when you say that. Because when I think about the traditional physician, I think of the traditional physician going, I want to make a change in a single person's life. And you're like, no. I've done that. I enjoy that, but I want to do that at a much bigger scale. So what do you think changed for you, where you pivoted from that one-to-one to a one-to-many model?
Yeah, I mean, for me personally, it was due to personal family situation where my mother-in-law, brother-in-law, and mom were diagnosed with pretty significant conditions. So I became a caregiver, and then ultimately saw what after having to do that for about 2.5 years, taking a break, it just became something that I didn't realize. So what happened to me was, when I was taking care of my family, I actually started, to just as a hobby, convince my wife that I had to refinish our basement and build a home theater. So I did that. It was just something, it was typical, guy stuff, right? So I did this, and then friends and family would come over, and they're like, "Hey, who did this for you?" Like, it was just unplanned. I had no idea how to. It wasn't even something that I thought about, was to run a company, but it was just one of those things that I found out what it was like, right? You found a problem, other people had this need, and so I started to help friends and family to put systems together. And then before I knew it, I was like, wait a second, maybe I can get better pricing for this if I could buy, in bulk, right? So then I that's how I basically started my, the first small business basically was just designing and partnering with the local builder and giving them the plans to go and build these, home theater systems in the basements for people to remodel. And I started making more money doing that than, going back to finish residency during my break. And I was like, wait a second, this is crazy. Like, why am I killing myself when I could probably do this? And we had our daughter at the time. So it was just better lifestyle in terms of what. And so I didn't know what it was like to start a company or build a business. But yeah, so that evolved, and we started doing more from residential to commercial projects, and ultimately build an ad network that was IP based on top of gas pumps to sell ads at gas stations. So it was just an evolution of so that's what happened. And then the economy tanked, and because of my medical training and background, I somehow was recruited to join MD Links. So MD Links is a physician portal for those of you don't use it. It's a site that you can go register for free, and you get to keep updates or get daily updates on the top 10 relevant news journal articles that are relevant to your area of practice. So the person that hired me there was actually Steve Smith, one of the founders of Medscape, along with Peter Fischoff. And yeah, it was a fascinating kind of journey. But yeah, so that's how I got back into the medical side of things. And then so that's how I, my first foray into actually starting something was to validate an idea I had. Started being at MD Links was great. I got to see a lot of research. And one of the first interesting aspects of seeing where things were tracking in this intersection of technology and care delivery was the use of mobile tools, right? So texting, for example, and how you could use it for smoking cessation programs and potentially, diabetes management. And there was a great, still successful program called Text for Baby that allowed pregnant moms to get prenatal care by simply texting in their expectant delivery or due date. And so this, was kind of percolating in my head, and I actually saw this opportunity at Datapalooza, which is a health conference here in DC, where there was a hackathon the weekend before the conference started. So I was like, oh, I wonder if any of these ideas, are hold any water. So I showed up, and the session was how can you use open government data? So Medicare was opening up these data sets, and they wanted to showcase how folks could use them to solve and manage medical conditions. So this was the focus was obesity. And so, I showed up, had an idea. 4 guys and a girl, I think, came up, and we all built this thing from Saturday afternoon to Sunday afternoon when we presented. And we won 3rd place and I think $1,200. But the cool thing was the solution we built was kind of based on this engaging, or how do you maintain that doctor-patient relationship and help patients manage their, what doctors typically tell you, right? Go home and eat better and exercise, and we'll see you in 6 months or a year.
Yeah.
So patients are kind of left to their own devices. So this idea, taking into account the research that I was reading, and then I had been introduced to BJ Fogg's work in Stanford about classifying behavior types and then finding the right motivations and triggers to get people to. So a lot of healthcare, if you can improve people's outcomes, is getting them to do the right things, right? If you can continue to take your meds as they were prescribed, or make better choices for your diet and activity, you are able to help improve the lives of a lot of the people that you're helping to better. And so that was what the thesis was. And so we after we won, we actually got a chance to go to the conference as part of our award. And so I remember this. I was actually sitting in a session where the pioneering ACOs back in 2012 were sharing their outcome data on the ACO model. And so this was part of the triple aim, and do ACOs improve quality of care, reduce costs, all that stuff. And the room was packed because it was moderated by Atul Gawande. And so I happened to sit next to this guy who I was just chit-chatting with before the session started. And he looks at me, he goes, what are you doing here? And I told him about the hackathon and showed him what we built. And he looks at me, he goes, wow, can I buy this from you? And I said, literally, so that was my, you were asking me how I got into this entrepreneurship. That's literally what happened. So in my head, I was like, wait a second, we took this idea, built something, and potentially had a customer in 3 days. And that was the need, right, back in 2012. Today there's a lot, you can see the progression of how a lot of these technologies and solutions have been kind of built out and scaled now. But so that was the opportunity. And the reason he was interested was he was starting an ACO in San Antonio, and they had a large Hispanic population that had standard feature phones, and texting was a primary means of communicating. And he was interested in using what we had built as a way of continuously engaging with their patients outside the doctor's office and getting them to manage their diabetes better by improving their diet and exercise. So that was what he wanted to do. But unfortunately, I couldn't sell it to him because the team that was together at the hackathon all scattered back to their day jobs the next day. But unfortunately, one of the folks I got to meet there was Aman Bandari, who was part of Todd Park's team at HHS. And Aman put me in touch with the folks at Blueprint Health, who is a digital health accelerator that was modeled after Techstars, that launched literally that year or earlier that year in New York. And so went to meet Matt and Brad and shared with them the idea, and they loved it, except they had just selected their 9 companies for the current cohort. So literally the week before. And so they gave me 2 choices. I could reapply for the January 2013 cohort, or if I promised not to work on my idea, they want me to come up and mentor their 9 companies, because I don't think a majority of them had a clinical person on their team. So I took all my vacation time at MD Links and went to New York, and that was it. Never went back. It was an amazing experience being around some passionate folks, building some amazing things, and it was just the energy and the drive and the passion was just contagious. So that's the definition of an entrepreneur there, right? So you basically are surrounded by folks taking all these challenges head on, and proving out that there's a better way to do things.
So you talk about how this journey, to me, it really represents in many ways. If I had to put a mental picture to it, it's you being Tarzan and basically taking every sort of route or whatever it is that he has, and going from one link to the other, each time thinking, I don't know if there's going to be another one waiting for me when I get there, and that's scary. And that is that part of the reason most physicians probably start, but think it's too dangerous a path and therefore don't continue. Because there's definitely a pull to know that you're on the tree the whole time and that tree trunk isn't going anywhere.
Yeah, like I said, it all comes back to your level of risk tolerance, right? So everybody's background and personal situations are different, and so, but yeah, it's that it's literally like taking that leap, right? Knowing that you're not going to know how you're going to land, but the first step is taking that jump. And if you can't take that jump, then you're not ready, right? So that's and everybody, all the founders that I've met and talked to, they all have that moment when they're like, yep, it's just take that leap of faith. And what it is because as you're falling, you're solving all these problems, building this out, fundraising. It's just like a million things you're doing to make yourself as successful as possible. But the hardest thing is taking that first step. So a lot of like I said, a lot of physicians, and it's unfortunate, and that was part of the reason why Health for America was started, was to help doctors, nurses, practitioners that are seeing these challenges day to day, but just don't have the means because they're busy taking care of patients, or they can't step away. They just don't know how to get started. So this fellowship program paired recent college grads that had interest in healthcare but no healthcare background, but had the passion, the drive to solve these problems, with somebody that experiences these problems every day. So the program that we first started was partnered with was at Christiana Healthcare and around CHF. So the fellows, after working for 12 months, came up with the idea was at the end of this program, you come up with a sustainable idea that you can then becomes a vehicle for starting a company, right? So that was the program model, and so the first one was CHF, and the intervention and what they validated as an idea was to embed a bath mat with a weight sensor that you can collect daily changes in weight for patients without having them to change their behavior or activity, and then use that as an early indication for interventions to help manage the CHF patients.
So you talk about how you started Health for America with this goal, but now you're also at you did some work at Medici, and you actually are now at Blue Stream Health. How does that fit into your vision? Are you still do you find yourself having a singular passion that you're trying to solve, or is it always multiple interests that you solve at any given time in your life?
Well, I mean, there are so many challenges, right? Everywhere you look in healthcare, there's a problem to be solved. For me personally, the opportunities that I've been able to, partner with some amazing people and work with some great teams were just kind of the evolution of how you can use the tools that are around you to solve the problem. So for me, it was always, once I got back into the healthcare side of things and on the entrepreneurship side, it was, kind of knowing what I wanted to tackle in terms of the problems that I was interested in addressing. And for me, it was always kind of back at that hackathon, right? It was around the way that you can use technology to drive patients and add value to how you can deliver care for them. And so that's kind of what, in my head, it was anything that fits into that framework is something that was interesting to me. So that's why at Health Recovery Solutions, the startup at Blueprint, where the idea was, how do you create that circle of care around a patient who is getting discharged from the hospital? The goal was to optimize the care for the patient, but the thing that made it sustainable was the benefit to the hospital was that you're preventing a readmission. So that's what makes a lot of these models challenging in healthcare, is that you're not sure who's paying for what service, who's getting the benefit. Ultimately, the end user doesn't know anything about the costs of the care because it's all kind of disconnected with all the layers of the bureaucracy and just the way the healthcare system is built. So that was the problem that we were solving, which was focusing on how to make the patients better, managing their CHF. But the economic model was, what is the benefit to the hospital who was at risk for a potential penalty for readmission? So, but so that's, and then at Point of Care, the second company that I had the fortune to work with, Bob, who had started MedPage today prior to starting at Point of Care. The goal was, how could we drive better patient outcomes by enabling access to evidence-based information in a way that is faster than is typically available to the doctors at the point of care. So we were the first ones to leverage the IBM Watson tech stack, if you will, but we're able to customize it for our application, which was delivering point of care answers to clinical questions that were asked by just speaking to our app, right? So natural language processing takes in the information, processes it, and then can share back a CME-based answer. So you can actually earn CME credit for asking clinically relevant questions. And if you know MedPage, right, the model there was, the unique thing with MedPage was you could, as a physician, you could go read an article in the New York Times about a new drug or therapy that was just announced or approved by FDA. But if you read that same content on MedPage, you can get CME credit for it, right? That was the unique process that the team had figured out. But what we did at Point of Care was took that a step further. And what I learned at Health Recovery Solutions was a lot of these medical directors and heart CHF directors or nurse practitioners, while they were solving this problem, which was important, they kept asking, what could we do to make sure that our doctors and nurses and our providers are managing these patients optimally to start with, so that these patients aren't at risk. So that are we doing everything we can to manage these patients effectively to make sure that the right things are being done when they go home, so that it reduces the amount of potential patients that are at risk for getting readmitted. So it was the challenge was using the question they were asking was do you guys have any training programs for teaching our doctors and nurses, which we didn't. But so that was the kind of aha moment for me, was like, well, what if we could take these quality measures and metrics that doctors are always being measured against, which hospitals now are responsible for showing their quality, right? So this was back in 2015. And what if we could actually tailor your learning as a doctor, nurse, clinician to your personal quality gaps or your personal knowledge gaps, right? And then build a custom program where you are learning based on what you need versus what your colleague may need, right? So a lot of these generic CME programs, well, everybody does it, right? They wait till they're 2 weeks before the license is due. They take 20 credits so they can check the box and, I got my 50 credit hours of CME. So we wanted to change that. We wanted to, so back in 2009, the Institute of Medicine actually wrote a report on the learning healthcare system, right? So we were actually, that was our vision, was to, how could we actually build that? How could we take data? And, before where we are today, where you have, robust EMR access, and you can break this down and kind of see that coming true now. Back then, it wasn't. It was all really based on what the doctors and the patients were doing with each other. Like, how am I learning from what the patients are doing, and how are the patients able to show me what we agreed on as a care plan? How well was it working? So the first thing we did at Point of Care was to focus on multiple sclerosis as an area. And so what we did was partner with the MSA, Multiple Sclerosis Association of America, and we built a mobile app for their patients to track MS, right? MS is a progressive disease. The more information you can collect about how you're progressing with that disease and how you're managing your symptoms, and you can share that with your doctor the next time you're together, the more insights I have as a provider to help my patients. But more importantly, if I have questions now, I have our AI tool that can help me answer those questions and get CME credit. So that's the loop that we wanted to create. What was that loop that we can connect between patient outcomes and patient-reported data and the management of that patient?
So this is so interesting. It's I don't know if you've noticed this about yourself, but I'm sure you have. The one thing that you keep coming back to over and over and over again is education and engagement at the point of care. And you saw that in that first at Datapalooza, where you actually had a text-based system. You saw that when you're talking about educating doctors, and you saw that even at the point of I'm blanking, but essentially when you were training the physicians at MD Links, and what data do you give to them? And now, quite honestly, you're seeing it at Bluestream, where you're talking about telehealth, where patient needs the information at the point of care. I happen to agree with you completely that that is the moment when you need the information. It's great that I'm reading things in the background and getting a comprehensive overview, but right now, a patient in front of me or a patient needs something at this second. How did you consciously come to the decision or the awareness that that's the that's the point that matters, or was there something else that went into it? Was this a conscious decision, if that makes sense?
Well, I mean, no, it's because, before where we are today in terms of virtual care and telemedicine, because of what COVID has done. Remember, the majority of the exchange of information takes place in person at the point of care, right? So where are you going to able to make the most impact? It's when you're with your patient, and so that's why it made sense to be able to have these tools. And I don't know if you follow me on Twitter, but the thing I have pinned on my Twitter timeline is, strong patient-provider relationships drive healthier outcomes, and that's how that's what I believe.
I totally follow you, by the way. But there's no way I remembered that line, by the way. But having said that, so let's talk a little bit about what telemedicine looks like. The news you actually tweeted out yesterday was the Walmart news. And again, I've already forgotten the name of the company, but they bought a telemedicine provider. The news also was Amazon's sort of hardcore getting into this as well. Why are these entities looking at telemedicine as the solution, and solution for what? Like, they're both what I think of as non-healthcare providers. They're sort of getting into the space. Is it just the money, or is there something bigger at stake that you can see them sort of seeing value in?
Well, I mean, it's a couple of factors, right? I think at the end of the day, I think it comes down to everyone someday is going to be a patient, right? So, so we all have a stake in this. And, the last time you went to try to go see your doctor, or the last time, your mom or grandmother was in the hospital, the experiences in these settings are not what consumers experience in any other aspect of their life, right? So the reason you see so much money being poured into this, especially now post-COVID, in the first quarter, there was something like, I don't know, $3-4 billion invested in these companies, companies that are non-traditionally what you would think of as delivering care, right? Companies like Roe, that was started as a prescription delivery service for, is now being able to go after and deliver primary care. So so same thing with Amazon Care, right? Which was Amazon creating these encounters now where or opportunities for consumers to get care outside the traditional setting. And it's because these companies know how to make the experience of selling you things or delivering things, more, I don't know what the word is, but fun, better, engaging. So that's why you see all these entries. And Walmart's unique, right? Walmart, they have something like access to 50% of the population, and they have already been doing or exploring how to do clinics in the Walmart. So the announcement they made yesterday was access to specialty doctors, right? Which is the ability now to kind of deliver that whole comprehensive service for their associates and their potentially consumers in the vicinity of these stores. And so I think that's what you're seeing is that companies are realizing that if we have that relationship, right, that we can make it a better experience for consumers to get access to, and we can deliver care in a way that is easier to access, less expensive, then people are going to gravitate towards that.
Now I'll give you my experience though with telemedicine, and tell me if yours has been different. But I had to go see my therapist, and during COVID, I was like, I'm not comfortable seeing a therapist right now, in person. However, when I tried the telehealth solution, and I recognize we're not talking about therapy, if you will, but I think there are corollaries to it. In the context of having a conversation, it didn't feel like I had the same connection with her when I was talking to her. Is that something you've seen being raised to you in the context of telemedicine, where patients are saying, I feel like I'm coming to my physician, and I can see myself saying this, which is why I'm saying it. I can see myself coming to a physician for a very clear, I know I need this, and you just need to talk to me to make sure I'm not making things up. But for, say, I don't know, oncology or something like that. I'm not sure I want to do this online. I want the doctor to see me. I want them to get a feel for what I'm looking at. So what has that experience been like? Are we getting into a more mature form of telemedicine than we were, say, even a year ago?
Yeah, there's a lot of stuff there to unpack. Yeah, so first of all, like you said, mental health, behavioral health is still the number one use case for, remote virtual services like telehealth services, because there's not a lot of physical exam involved, right? It's therapy, like we're talking. But what's happening, or what COVID has done, is accelerated the learning required both on the patient side and on the provider side, right? So doctors have now very quickly been able to figure out what are the things that I'm comfortable doing virtually, remotely with the patient, and what are the things that I need to see the patient for. So that's the first thing, right? So you would likely have gone through some sort of a screening protocol or followed, some sort of methodology that would figure out, does Darshan need to come in and see me physically, or does this qualify for a visit that we can do virtually, right? So that's what a lot of learning has gone into, and patients are more comfortable doing more and more of these virtually experience, because some of them already have devices, like they're collecting biometric information, right? They're collecting temperature, heart rate, blood pressure, weight, and so they're more comfortable sharing that information, and the doctors on the other side to evaluate it. Now, what's the shift that we're seeing, and this has been interesting at Bluestream, is that COVID kind of also accelerated the adoption of telehealth tools, right? So before, when Teladoc and Amwell, like 10 years ago when they started, it was just, could we get access to a doctor? Not your doctor necessarily, but could we just get access to a doctor, middle of the night, or I'm traveling, my regular doctor that I see, in Philly, and I'm in California on vacation, who do I talk to, right? That was a great problem to solve. And then as these methodologies became more, acceptable, then patients were like, wait a second, if I could do this with any doctor, why can't I do this with my doctor, right? Like that was that relationship. And so that's what Medici was about. Like, how do we allow, or how can we make it easier for patients to maintain that virtual experience, but do it with their own doctors in a way that it fits into the doctor's workflow? And so that was a primarily SMS chat-based asynchronous way that you could connect with your doctors and they could connect with you. And then now, so what happened post-COVID, right? So there's like this whole world, pre-COVID and post-COVID. So post-COVID now, everybody accelerated that learning of what could we do remotely and what can't we do remotely. And more importantly, it became so obvious that those old ways of I need to talk to someone right now, get me connected. So those are like episodic point encounters, right?
Yeah.
And when you have someone like yourself who may need a therapist, but maybe you have, or not you specifically, but somebody has managing multiple conditions like hypertension or diabetes or heart failure, and they now, in a virtual setting, it's no longer enough just to have you talk to your doctor, or that. So if you try, that's fine if you can schedule 1 or 2 patients a day, but now 90% of your patients are virtual, right? Yeah. Those old kind of solutions are not scalable. So what we're finding is having to shift to this new thinking of, okay, you've done telemedicine where you can have access to somebody, but now how do we actually deliver care virtually, right? How do we deliver care remotely, wherever the patient is? So, this whole idea of care in person versus care remotely, we call it telehealth or, virtual care, but it's all going to just, as Jamie likes to say from Cloudbreak, it's all going to be care, right? It's just where you get that care. Is it in person or it's going to be remote? But so that's what we're seeing, is that a lot of folks trying to figure out, okay, now we need to do a virtual program for managing patients who are chronic conditions at home. We need a virtual care program for delivering psych consults inpatient. We need a virtual care. So you fill in that blank. So now systems have put in 5 or 6, 7, in some places, over 10 different solutions to handle these challenges. And interestingly, pharma has been, kind of looking at this as well, right? So how can pharma companies support this shift to kind of value-based care models, where you're now getting reimbursed for these high-cost drugs on the outcomes? So if you can create, this whole concept of beyond the pill, right? This whole idea of creating a digital service, And it's now, starting to see, happen, not the other end of the spectrum, which is digital therapeutics. I'm just talking about you're on therapy X. What are the resources we can wrap around that so that the patient can stay successful? And a lot of that now could be done remotely or virtually, right? So that's where things are shifting to. Is in the example that you said, I'd like to talk to my therapist, but sometimes if I'm an oncology patient, I may have to come see the doctor. But yes, you're absolutely right. But now if you start looking at the circles of care around that patient, the patient should also have the opportunity, without having to pick up the phone and trying to figure out who to call or how to schedule an appointment to, simply click a button and have access to their care team who knows that patient, who can then, as you and I are talking, imagine I'm the nurse and you're the patient, I can quickly do an evaluation, and I should be able to seamlessly replicate what happens in a hospital or clinic setting. Like you would go down the hall, you'd sit in an exam room, and then you have people coming in and out of that room. First is the phlebotomist, right? Or somebody checking your vitals. And then the doctor comes in. The doctor says, okay, great to see you. I'm going to send in the diabetic nurse to talk to you about this. The nutritionist is going to come see you. And then before you go, we need to collect some blood and then schedule your follow-up visit. Like 5 people saw you in that 15, 20-minute encounter. Imagine doing that in a call like this, right? That's where things are moving to.
So it's interesting you talk, and we're past the time I thought we'd take, because you're just fascinating to talk to. But you talk about the whole beyond the pill and the value-based care model. It's interesting from a legal perspective. There are limitations. There are actually potential anti-kickback issues that kick in if you're talking about using a beyond the pill model. Having said that, I do think the law's going to have to adapt.
Unless you get a waiver, unless you get the waiver for, value-based care, or if you're an ACO, or if you're, there's models that you get waivers for that.
There are models you can get waivers for. You have to be careful though, even with those models. I've worked a little bit in that space, and I've worked a lot in the pharma space. But it's been interesting, because one of the issues you end up with is, can you get reimbursed? And the second issue that comes into play is, if you're looking at if you're the pharma company, unless you have like a waiver, or unless you have like a decision from CMS saying that we aren't going to prosecute or something like this, it's very dangerous.
Oh, sorry, I didn't mean to conflict. So pharma companies are separate. I'm talking about the waivers for the providers who are creating that care team around the patient. So, self-referrals and things like that for anti-kickback. Right. But for a pharma company, where you can add value, though, is provide that support infrastructure. So if I'm a primary care doctor that is prescribing a certain therapy, I may not have a staffing resource to say, if you have questions, call. But there's these support mechanisms already exist in pharma companies, right? All I'm saying is make those available in a way that helps make those resources more readily available, and close that loop between the provider and the patient.
Conceptually, I agree with you. Conceptually, I think that's a great idea. I think what you have to start worrying about is that considered to be some kind of payment to the payer?
Oh yeah, that's the trick, right? $25 or less now, or $10? I forgot the number.
Looking at the Sunshine Act. Yeah. I'm not even thinking of the Sunshine Act. If I'm helping you, are you more likely to prescribe my drug because I helped you?
Gotcha. Yeah.
So the Sunshine Act is just a reporting mechanism.
Correct. Well, so isn't there a way you can work on that, Darshan, by making it universal, so it's not dependent on the therapy, but just say, here's a pool, right? Here's the resource pool that you can tap into. It doesn't matter if you're on AZ or BMS or whatever it is.
It's funny you say that. There's one of those things that people have been talking about, pools, but I'm not aware of an actual letter from OIG saying we'll consider pools to be exempt. Yep. Because what you're talking about is the same exact mechanism for patient for cost of care issues. So patient needs the drug, your drug's too expensive. Can I put my drug and other drugs into this pool, and therefore the patient gets whatever they need? Conceptually, you'd think that that'd be okay. But I haven't seen, and I'd have to look a little bit deeper, but I haven't seen an explicit waiver saying that's okay. So conceptually, I think what you're saying makes complete sense. Like, aren't you de-risking it? Aren't you saying that it's not an individual pharma company giving me anything? But the government's perspective is, well, what if if there are 20 companies out there and only 2 of them participate, you're now saying there's a pool, but is it really a pool? Right, or you're the only drug out there for this, and you say there's a pool, but you're the only one on there.
Correct. So the what they want to avoid, it seems like, is that you're adding a value add service that's kind of pushing you to prescribe drug A versus drug B. even though the therapeutic, efficacy may be the same, you're kind of tilting the scale a little bit. Okay.
Exactly. So those are the types of issues you have to think about. But conceptually, you're 100% right. Because in the end, aren't we all, including the government, including pharma companies, trying to actually help the patient in the end?
Yeah. So that's what's been a little challenging, I think, for pharma companies, right? It takes them, they are extra vigilant because these everyone knows and understands, but actually implementing these programs, I think, where it gets challenging. So.
And they're explicit. It's funny. In the value-based care model, they came out with 2 new exceptions, if I remember correctly, to include value-based care and explicitly disallow pharma from participating, except in the context of I think it's health tech. But we can go down a whole discussion on that.
Yeah, that's a whole other topic.
It's a reason to have you back on. So here's a question for you. Based on our discussion, what is one question you'd like the audience to answer for us?
I'd like to know how they are addressing, this shift in where care is going to happen, right? So, how can we make that experience better for patients and, for people in general, if they need to engage with getting care, and how are organizations thinking through delivering that care? So wherever it is, in person or, remote, you are doing it in a way that fits in with your resources and workflows, and it makes it easy to access, and you're actually adding value in delivering that care. So that, how are you doing that? That's my question to them.
So I think I'll try to answer the way I understood the question. I think what I really liked about what you proposed was this idea of almost replicating the in-person model online, where you walk into the room and you've got the phlebotomist coming in and the medical assistant taking my vital signs. All of that stuff's happening almost virtually, and the physician gets all the information that they need as they come on. The other opportunity I think that might exist is the idea of actual video conferences, where I can be listening to all 5 of the physicians who are taking care of me, and they can talk to each other instead of just passing notes around.
Yep.
And that conversation can happen, which is not something that's easy to happen.
Yeah. So you bring up a really interesting point, right? And that's actually, I forgot to mention this. So that's one of the key differentiators that we offer at Bluestream, is that you have access to embedded interpreting services in video. So if one of the biggest challenges during COVID was that the widening of the inequity that takes place, that already existed, but once you add this whole digital layer to it, that digital divide just increase that gap between access to care, right? For folks that were in communities that didn't have broadband or didn't have mobile devices or tablets, they couldn't go to the library to access the computer because COVID said no. So where are they getting their care? And if they could get their care, they needed interpreting services to be provided in a video visit like this. And it's not easy to incorporate live interpreters on demand when you need them, especially for ASL, right? For deaf patients. So those are all challenges that we actually solve on the Bluestream platform. So you can actually have, while we're talking, push a button and have a video interpreter join in, typically within 30 seconds or less, into these calls.
Oh, wow. Okay. Fascinating. So that is how I would want the solution. What I worry about is the moment I start saying things like, we're going to have a digital virtual visit versus a live visit, I worry about the payers in the world going, you know what we're going to start doing is start paying physicians less, require that everyone goes through digital first. So that way we're cost containing. And as a result of that, you just add bureaucracy to a system which was supposed to be about choice, which is sort of what happened with drugs. Originally, it was supposed to be, you take the drug your doctor tells you, and we'll pay for it. Now it's become a stepwise approach. Everything needs to go down. Conceptually, I understand the process. Logically, I understand the process, but I kind of feel like I'm now jumping through hoops.
Yeah. So to your point, though, right? That's why these new reimbursement models that are coming. So I don't know if you've been following, this trend of direct contracting entities. It's kind of the expansion of the ACO, Medicare Advantage model, right? So new groups, new models like IRO Health, and Scan, like these companies or these health plans that are being created, Medicare Advantage plans, that are getting a set of dollars to manage the care of the patient. So those models allow me to enable the best services for my pool of patients, right? So some of them may best be handled virtually, which means I now have capacity to see those patients to be seen in person. So so it works both ways, right? So it's not about doing it, everybody gets this, virtual screen, and then you determine. It's more around what is the best for the patient and how can I best deliver that care. So sometimes it could be virtual, but sometimes it needs to happen in place, or it could be in the patient's home, right? So there's this new shift to home-based care, where you're now shifting where that care actually takes place. So there's and these models that allow you as the care delivery entity to determine where and how that should happen. That's why I don't think it's going to be so much more in what's happening in the fee-for-service space. It's more going to be around how do we best manage what's needed for the patient.
What I think is interesting, though, is you mentioned this idea that it would be based on what the healthcare practitioner, the physician in this case, thinks is best. What about the patient?
Yeah, exactly. Yeah. So that's the thing, right? So you get to determine, like in your case, if you're comfortable doing it virtually, that's great. If not, and don't forget, a lot of the times it's not just the patient, but it's the caregivers that are responsible for managing the care of someone, especially the elderly population, right? That's taking place. So yeah, so there's all of these factors that need to be considered, and ultimately, you can't force somebody to do something. It's ultimately going to come down to, like you said, it's that doctor-patient relationship.
Yeah. So I do want to do a quick recap of what we discussed. During this conversation, we start talking about just your journey as an entrepreneur, and you talked a little bit about team building. You talked about revenue models. You talked about your internal motivation, things like tolerance of risk, the impact you can have, the dissatisfaction you had trying to come in. Interestingly enough, and I wasn't expecting this, the whole origin of this was how you started building your own home theater, which to me is kind of awesome because I built my own home theater.
Oh, nice. We can talk offline about that.
For sure. But then how that transport over to an ad network, which is interesting to me because I actually have known gas stations. So I'm wondering if I have one of yours right now. But I had that. But then you got into MD Links and how Steve Smith got you in, and then how that sort of played out with Datapalooza and basically the texting and smoking cessation program. You talked about how you originally started off with using, as part of Datapalooza, these open government data sets, and how you are using behavioral science almost to actually nudge people to move down the pathways. You talked a little bit about this idea of disconnected payments and how you can actually might be able to get better patient outcomes at the point of care. And we pointed out and discussed how that how that seems to be a recurring point in the processes that you've been following. And like I said, I agree with you 100% that's where you're going to make the maximum amount of difference. You talked a little bit about some of your experiences using IBM Watson and using natural language processing, which interestingly enough also included giving people CMEs. I really wish you had CLEs or CEs, but that's a point for a different discussion. And then you talked about just data collection and MS, and I really wanted to get into that, but we jumped in a different direction. But I was very curious about who owns the data and what controls the data and those issues, because I'm very interested in data privacy. And then we talked about this whole beyond the pill model, and we talked about direct contracting models and value-based care. Did I miss anything?
No, we covered a lot of stuff.
This was really good. So thank you so much for being part of it. I do have 2 more questions for you, if you don't mind. They're rapid fire questions.
Sure.
Okay. What challenges you?
Doing the best I can to make sure that that I, making whatever dent I can in making healthcare better for others.
What part of that is a challenge?
Everything, right? So the challenge is that's the thing. That's my, the reason you wake up in the day is making sure it's getting, making sure that other people's that come behind us, they don't have the same challenges, basically, right? So making sure that we're doing what we can so that my kids don't have to struggle with, how do I get my care this morning?
Oh, that's a really cool challenge. Your challenge is to make sure that someone else doesn't face the same challenge. I love it. What is the best part of your job?
I get to meet some amazing folks, especially during COVID, met folks that went way and beyond. It's just people don't understand the reality being in healthcare, the colleagues that are taking care of patients, and our partners and clients that are implementing these solutions and actually seeing it work, the impact that we got to make. Like, one of our partners went from doing 7 virtual video visits a day prior to COVID, over 5,000 a day on our platform. And in 2 weeks, we were able to help them shift from that model. So it was just I can share countless stories like that. So that's what's been really exciting, is to see and talk to folks that are actually doing that hard work and putting at the early days risking their own lives to take care of other people.
Yeah. We should clarify, nothing in this podcast should be construed as legal or clinical advice of any kind. It's intended for educational and entertainment purposes only. For those of you who missed it, Sandeep, where can they reach you?
I'm on LinkedIn. I'm on Twitter. So you can just find me. Just search for my name.
Very cool. If you like this podcast, please leave a comment. Please subscribe. You can find me at Darshan Talks on Twitter, or just go to our website at darshantalks.com. And Sandeep, this was wonderful having you on. So I'd love to have you on again, continue the discussion.
Yeah, if you're on, I would love to. And if you're on Clubhouse, maybe we'll run into each other in Clubhouse someday.
For sure. Talk to you soon.
Take care. Bye.